COPD Foundation has nice videos on how to do inhalers, which is a nice way to like teach neighbors who say, I've got an inhaler and I don't know what to do with it. Just because they have the flu, it was probably that it wasn't really that they needed that, but they don't even know how to use it. So COPD Foundation's a nice one. Alzheimer's Foundation, but not Alzheimer's.org, has great educational things for, we'll call the general public. So some places have nice things. I will tell you the two Alzheimer's associations, one focuses on funding, which I don't care about. But if I want to be certified as an Alzheimer, like a person who runs some program, I have to get certified from them. We do have monthly Zoom meetings based on the state that we're in, but not every state does that either. But for focusing for, when you have the lay people who are like trying to just point out to how to use equipment and stuff, certain ones are better than others.
Well, thank you. I'll definitely pass along to our education and communications teams that we made the better side of that list. It's interesting. There have been some studies out there where organizations have looked at how the content is delivered, or like when we have an inhaler education video, for example, is it hitting all the key components and things like that? But I don't know that anybody's really looked at usability or anything like that. So it'd be an
Mm-hmm.
interesting study to put out there.
Well,
Are these things? Sorry,
I used
go
to
ahead.
take some of the videos and just pull up the URL on it. And I used to have a Better Breathers group, which I could pull up on a computer and everything to help. And if somebody had a question, they're very easy to just pop them up in there, which was nice on for that part.
We also, and again, I don't want to turn this into too much of a foundation thing, just, again, with that confusion floating around out there, but we have an app that is on the iOS, the Apple App Store, and Google Play Store. It's called the COPD Foundation Pocket Consultant Guide. That has links right to those videos that you can show on your device or anything like that. And then it also has some things like assessment tools like the chronic airways assessment test and the MMRC dyspnea scale and treatment pathways and all that kind of stuff. So I'm sure there are some other great apps out there as well. Digital health is really an up and coming sector. And so if you find the videos useful, that's great. Otherwise, there are a lot of other ones out there. So, yeah,
Mhm.
cool. All right. So let's see. One thing I did find, one thing I probably should mention also, is there is a new recall for oxygen concentrators. I'm going to drop that link in the chat from HME News. There we go. This is for the True Air 5 oxygen concentrator due to the device spontaneously catching fire, which is generally a bad thing when it comes to medical equipment, specifically medical equipment that creates oxygen or concentrates oxygen. The FDA says all units from a specified serial number range must be immediately discontinued from use and removed from service and promptly returned to Compass Health Brands, which is their U.S. distributor. These are devices that are manufactured elsewhere, but they are distributed here in the U.S. So hopefully, if your device is covered under this recall, or if you're a patient and your device is covered under this recall, you've heard from your DME supplier already. But if you happen to be a DME RT that whose company handles True Air, or you've seen some of these out there, that sort of thing, or you're working in pulmonary rehab and you happen to know patients talk about their concentrators, so on and so forth, please be advised of that and work to get those out of service. So far, it says no reports of death, no reports of injuries so far either. But of course, if oxygen equipment is catching fire, and nothing is done about it. It's probably just a matter of time. Another interesting article that I came across from on the oxygen side of things, a little bit better news. This is an article I will also put in the chat from UNICEF that is talking about solar-powered oxygen concentrators in the country of Nigeria. This is it's been an ongoing topic in low and middle income, resource poor areas of the world for a couple of years now. They, like the rest of the world, got hit pretty hard with COVID, and a lot of their hospital infrastructure and was really damaged by, or really strained by, the demands placed on it by COVID. And again, these are places that don't necessarily have the infrastructure for long-term oxygen. For example, there's a story that I need to see if I can find an update on, but there was a story last year about a 14-year-old girl, in Africa. I can't remember exactly what country, but she was stuck living in a hospital because I believe she was post-tuberculosis, and was still dependent on supplemental oxygen. But her village did not have 24-hour power, electrical power, so they weren't able to send her home with a concentrator or anything like that because there wasn't going to be available power. And so now again, imagine being a teenager and you're living in a hospital a half hour away from your home and your friends and everything else. That's a real bummer. So there have been some pushes to develop better concentrators that are more able to adapt to changing power, what they sometimes call dirty power, where it's changing amperages or whatever. Not an electrical guy, but that can sustain changes in that. But then also this particular article talks about solar microgrid systems with battery storage for uninterrupted oxygen production. And so this isn't necessarily something that is going to be for home use, but these are 100% solarized oxygen generation plants that can be connected to hospitals, and again, in relatively smaller areas, things like that where they can be a little bit more independent from power changes and issues with that. So that's cool. While that may seem perhaps it may seem a little bit odd that we're talking about oxygen in Nigeria, it's important to remember that we can take some of these lessons and apply them here in the U.S. I mean, we've had several natural disasters over the last 6 months or so. I'm thinking all the way back from the hurricanes that went through northwestern Florida and up into the Carolinas. We've had the wildfires in California. These things are happening, unfortunately, with seemingly more regularity, and they significantly affect people who are dependent or reliant upon a lot of this equipment. And so if we're able to take some of these things that may be created and developed for other parts of the world, we can also apply those lessons here domestically. Maybe not a one-to-one application, but if we look at disaster response and grid resilience and all that sort of thing, we can, in general, improve care for a lot of our folks with chronic respiratory problems. So that's those are the big things. Those came to me from my Google alerts, which are always a good thing to have if you are interested in keeping up with the latest and greatest in whatever content area. Mine are set for COPD and for oxygen, but those of you who are working with cystic fibrosis or pulmonary fibrosis or pulmonary hypertension, it's easy enough to set up a news alert. I would imagine, in the sense of being balanced, I imagine Bing can do the same thing, or your search engine of choice. I just happen to have been stuck in the Google ecosystem for a very long time now. All right. It's a tough crowd today. Not much going on. One thing I'm excited about is in about a week and a half now, I'll be attending my first MedTrade conference, which is, I'm told, the largest gathering of home medical equipment and device manufacturers in the U.S. I'm looking forward to meeting a lot of my colleagues in that industry, whether it's the suppliers or the manufacturers, or making a lot of other connections there as well. I'm hoping to have some conversations about the reintroduction of the Supplemental Oxygen Access Reform Act, or SOAR Act, which we do anticipate coming soon. Don't have an exact time on that, but last year it was introduced originally right about the time we at the foundation went and had our big Hill Day in Washington, D.C., which is in early March this year. It was in early March last year. I think it might have been a week later, but in any event, that was a weird thing. In any event, that is coming soon. Hopefully, we'll get some more information about getting that reintroduced. Also, upcoming are some bills related to virtual pulmonary rehabilitation. We tried to get that across the finish line at the end of the last congressional session. Didn't quite make it, but we are hoping to get that reintroduced, get that payment balance restored. And then I know there's also some legislation that is likely to be reintroduced that will also help improve access, should also help improve access to pulmonary rehab, where we can allow NPs, again, just working to improve access. All right, so let's see what else is going on in the world of respiratory care. It's a very casual Friday today. Speaking of cystic fibrosis, here's a headline that just came out today. FDA sets review date for chronic lung disease therapy. The FDA has accepted a new drug for pop-up ad, brensocatib, to treat patients with non-cystic fibrosis bronchiectasis. Regulators have granted priority review and have a target action date of August 12th, 2025 under the Prescription Drug User Fee Act. So that's pretty exciting. I know some folks who are working pretty intensely in the bronchiectasis space. What I know of the condition is it often overlaps with COPD, which means that it often goes underdiagnosed or undiagnosed, but really can have a big impact on life, because it's often chronic bronchitis supercharged, because your bronchi get dilated, and then you get pockets of infection and mucus buildup and all that sort of thing. A lot of times the most effective therapy has been high frequency chest wall oscillation or other chest physical therapy, but this looks to be a dipeptidyl peptase 1 inhibitor. There's a lot of biochemistry stuff in there, but it has to do with inhibiting proteases in neutrophils, and reducing their accumulation in airways, and hopefully slowing down the lung inflammation and other lung damage with that. So, good news for the bronchiectasis community. There we go. Andrew asks, does the COPD Foundation app have the ability to report app activity to their PCP or pulmonologist? Not directly at the moment. This is one of those things that this app has evolved a lot in the last, how old is that app? Better part of a decade, I believe, maybe even a little bit older. It evolved from basically just a repository of things like therapeutic flow charts and stuff like that into what is now a little bit more comprehensive. Now, the nice thing about it is there is a patient side and a clinician side. There's a little button that you can push, I think, at the top of the app that switches you back and forth. Largely, it just changes the presentation of the material, but it is a way for patients, for example, they can track their symptoms in the app, and then when they go in for an appointment, they can share some of that information with their clinician. We would love to eventually make that a little bit more automated and smooth that out a little bit, and because again, telehealth, digital health, that's all part of the new health landscape. It's just a matter of getting the resources and time and everything else to update that app. So it's on a roadmap. We're just not quite there yet. But in the meantime, there are some journaling functions that can help communicate with clinicians, or even just to keep track of vaccinations and everything else. Andrew also asks, what questions should be asked to help better identify bronchiectasis? So that's a good question. The formal diagnosis is usually done with the chest X-ray. There are certain signs that you can see on there that are hallmarks of bronchiectasis. But of course, that's not going to matter if you're probably not going to get a chest CT if you don't know you're at risk for it. So the symptoms are probably very similar to bronchiectasis. Like I said, I'm finding there is a questionnaire called the Bronchiectasis Health Questionnaire that assesses their bronchiectasis from the patient perspective. Let's see, this was published in the British Medical Journal a few years back. This is probably a little bit more of a ongoing, assessment tool for folks who are already diagnosed. So let's see, an NIH page that is still up, fortunately. That's cool. They suggest chest X-ray, chest CT, some blood tests, some lung function tests. So again, not a lot of screening tools available, it looks like. So I guess the biggest things in my experience, again, thinking back to my primary care days, if I had somebody who we were managing for COPD, we're trying to treat their cough and all that sort of thing, and they seemed just refractory to it, they weren't getting any better, everything else, we would do kind of our usual routine of, where does the cough seem to be coming from? How productive is it? How productive is it? And that sort of thing. And then we might, if we're getting to that point where we're just not seeing any kind of progress, that's when we would move on to, again, trying to get that more definitive diagnosis. So I guess questions to ask are, how often are you coughing? How productive is it? What color is it? Again, a lot of these folks are chronically infected, chronically colonized, I should say. Is there anything that makes your cough better or worse? Because a lot of these folks are going to have this dread cough all the time. It's not even going to be just in the morning or anything like that. Probably worse in the morning a little bit, but it's going to be pretty consistent. So, again, a lot of the same kinds of questions that you would ask somebody in the more general COPD space, particularly those with the chronic bronchitis side of things, are also going to be applicable. But again, it's trying to develop that diagnostic pathway to, as you're seeing these things, to get the docs thinking, well, maybe this person needs a little bit more radiology, stuff like that. So, excellent question. What else do we have going on here? All right, we'll go back to looking at some news real quick here until we get some more questions coming up. Well, now this one I'm very curious about. A website called Only My Health. I don't know exactly where this comes from. Warning, popular kitchen worktops linked to deadly and irreversible lung disease. aesthetic countertops in high-end kitchen spaces are bound to make you feel tempted to invest in one. But you might want to reconsider after knowing the plight of those who suffer from a fatal lung disease in the process of manufacturing these countertops. So this is actually a thing, even though this was just published today, this is a thing that I have seen growing over the last couple of years. Looking particularly at quartz countertops, there has been a huge uptick in silicosis in those people who are working, making these things, because a lot of them do not use or may not even have access to appropriate PPE as they're doing these, as they're working on the manufacture of these. So let's see. It looks like maybe there is a new article. No, okay. So this is from the link in this article does go all the way back to July of 2023. Excuse me, silicosis among immigrant engineered stone / quartz countertop fabrication workers in California. A case series of 52 patients, median year age diagnosis was 45. Nearly all were Latino immigrant men. Diagnosis was delayed in 58% of these folks, with 38% presenting with advanced disease, as they defined progressive massive fibrosis, and 19% ended up dying from the condition. So, this is again one of those things where outside of, I feel a lot of times outside of asthma, people think that, a lot of these lung diseases are things you brought on yourself. COPD is a smoker's disease and all that kind of stuff, where we really need to be looking at these occupational and environmental exposures a lot more closely, because they really do have significant impact on people's quality of life. I mean, again, these folks are 45, median age of diagnosis, in 52 patients, and they're in a vulnerable community, immigrants. Probably not going to have great access to primary care. We know that. Probably not having a lot of advocates in the workplace. So, we're going to be needing to really watch a lot of these issues again over the we're going to be needing to watch them regardless, but as some of the taste, their desire for regulations, workplace regulations and things like that change, we're going to need to be really careful to look at some of the long-term consequences of that and see what some of these repercussions are. All right, so let's see, what else do we have? A lot of strategic partnership stuff. There's something else interesting from the University of South Florida. COVID-19 may provide new clues on how to treat deadly lung disease. In this case, we're looking at pulmonary fibrosis. They're looking at so this group, led by Dr. Jose Harazo Maya, studied patients developed pulmonary fibrosis after contracting severe cases of COVID-19, and then started noticing that a lot of their pulmonary fibrosis got better when it was related specifically to COVID-19 and not idiopathic or anything like that. So, just published in the American Journal of Physiology. So their hope is that they can look at some of these COVID-19 patients and then figure out exactly what it is that is allowing their lungs to heal that folks with idiopathic pulmonary fibrosis may not have, and potentially lead to improved treatments for that. So definitely some interesting stuff going on. Just a matter of going out and finding it. I do think we're going to be starting to see more stuff start trickling out. We've got the ATS conference coming up in May, so usually in the lead up to that, and then at that meeting we see a lot of new stuff coming out. So be excited to see what all we get from that. let's see. Lung disease didn't give us a whole lot. Speaking of ATS, new guidelines highlight the benefits of pulmonary rehabilitation. As we know, less than 5% of folks who might be eligible for or could benefit from pulmonary rehab actually use it for a variety of reasons. And so a new paper in the Blue Journal, the American Journal of Respiratory and Critical Care Medicine, details the new guidelines and what they could mean for the future of chronic respiratory disease care. And this one looks, as we also mentioned, telerehab a little bit earlier. According to the corresponding author, Dr. Krishna Pandya, hopefully I'm pronouncing that correctly, she says, one of the ways in which these guidelines are new and important is that they are the first to evaluate the role of telerehabilitation programs in chronic respiratory disease. Transportation to pulmonary rehab centers can be costly and logistically challenging, so telerehab might be able to overcome some of those barriers. And the other potentially nice thing about having some guidelines like this is one of the issues that we've seen that we've heard a lot of from a lot of our advocates is there's a lot of heterogeneity in these virtual programs. Everyone is a little bit different because there haven't really been any kind of guidelines. I mean, even pulmonary rehab in general, yes, there are some clinical practice guidelines, but as with many of the guidelines out there, there's a lot of inconsistency in how they're applied. There haven't really been any in virtual pulmonary rehab because we're really it's only been in these last couple of years that we've been able to see longer term outcomes from it. So it will be really beneficial, I think, to the community to see exactly what does work. What are the best practices for these programs? Can they be done asynchronously? There's a large contingent that says no. There's some people that say maybe. There's certainly some of those folks who say yes. I don't know. I think we need more data on that. It would be really good to see what the best models are and how we can start building some of those out. So hopefully these new guidelines that I'm going to have to take a look at later on can make a difference in that. And let's see, another one from, this study comes from Mass General Brigham Hospital, looking at low-cost genetic samples that can be obtained from a cheek swab or blood test, helping improve identification of people with COPD in the community. So I'm sure many of us are familiar with cheek swabs or finger pokes for things like alpha-1 antitrypsin deficiency. Looks like this study is looking a little bit more closely at, come on, load up here, this is another Journal of the American Medical Association article, a polygenic risk score. So they looked at the COPD gene study and the Framingham heart study, and looked at those folks who did not, previously occurred smoke, adding a COPD polygenic risk score to the modified lung function questionnaire score significantly improved the identifying undiagnosed COPD cases beyond conventional case finding approaches. So I don't see quite what is built into that polygenic risk score. But according to this Medical Express article, it says it was based on genome-wide association studies of lung function that was associated with COPD. Excuse me. So anything, in my view, that can help us diagnose COPD more accurately and, more importantly, earlier is definitely a good thing. So also, I will say of the got a few people viewing here. Please feel free to drop a comment there if you're interested in learning more about that, or we can get you a link to that. or feel free to ask some questions. Again, this is a time for general questions. This is a time for section-related questions. How can we be providing better value? One of the big concerns that I have is there are a lot of RTs that don't belong to any membership section. And so one of the things I've been working on calling on the organization to do is let's have a bigger push to to get that going too, because it's difficult to many hands make light work. I'll say that. If we can get more RTs who understand the benefits of joining these, we have these meetings. I know the education section, I was just looking through some of their postings. They do a quarterly lunch and learn with various topics throughout the year. The leadership section has their leadership grand rounds. I believe they do it monthly. So there's a lot of networking and education and support that can be had through these membership sections. But a lot of RTs still aren't taking full advantage of that. So hopefully we can start moving the needle on that a little bit more. And that can certainly start with asking questions in the chat here. So please feel free for the next 15 minutes or so. In the meantime, let's go back and see what else is new. 2 days ago, do we have a new molecule coming? It was an exciting year last year with Dupixent and ensifentrine. Otuvray, I think, is the brand name for that. First new drugs for COPD in a while. And it looks like now, according to PR Newswire, this company called Harbor Biomed has improved, has in the National Medical Products Administration of China has approved the new investigational new drug application for a new molecule, a fully human antibody targeting thymic stromal lymphopoietin. I think that's how you pronounce that. We're getting all the fancy words today for the treatment of chronic obstructive pulmonary disease. So their thinking here is that by inhibiting this particular molecule, it will reduce airway inflammation and improve lung function. So this is a very early step in the process, but it is really cool to be seeing stuff like this, because for several years, COPD has just been kind of this afterthought, really. It's been something that hasn't received a lot of funding attention, a lot of research attention. And that does seem to be changing a bit as we get into some of these novel therapies and repurposing some of the things from the asthma world and some of the other respiratory drugs that are out there, getting those things into the mix. So, exciting times. Okay. Right, and now we're getting back into 2024. So those seem to be the most recent things in COPD in particular. Let's look at anything else new in pulmonary fibrosis. Researchers uncover the source of cells that contribute to pulmonary fibrosis. Well, that sounds like good news. A new study published in the journal Nature. Let's see. Team used advanced tracking methods that utilize RNA sequencing of individual cells. Looks like this was done in mice. Researchers found that pathological cells spring from normal fibroblasts marked with leptin receptors in the alveoli. And then there was a transcription factor, and disabling that was able to reduce the amount of fibrotic tissue in the lung by about 50%. So, again, we're looking at the first step in a very long process of potentially developing some new therapies for, in this case, pulmonary fibrosis. But anytime we start seeing some progress like that is very good news. All right, now just for the fun of it, let's look up respiratory therapy news. The University of West Alabama moving forward with a new health sciences comprehensive respiratory therapy track and is now accepting students in January for the spring 2025 semester. Has received provisional accreditation from AARC, according to Program Director Jerry King, so that is very cool. Always good to see some new RT programs coming out. So if you happen to be in West Alabama or know somebody in West Alabama who might be interested in becoming an RT, let them know about that opportunity. All right, well, it looks like we're probably going to be wrapping things up in a few minutes here. Not pretty quiet week, I guess. Again, other than few odds and ends here and there. We do see some good news on drug development fronts and everything else. So what I will say is, let's see, next week's not one of my mid-trade, is it? Already the weeks are kind of blurring together. No, let's see, we've got, so next week we'll do another one of these sessions. The week after we'll probably be able to, because I will return from the conference on Thursday, so we'll be able to have that coming up. We also, in a couple of weeks, have our monthly section meeting, which will feature, again, for the first time, we have a guest speaker that's going to talk about the role of RTs in long-term acute care. So if, again, if you're a member, definitely come in for that. If you are interested in learning more about how some of these roles work, please feel free to reach out to me here on LinkedIn or at mhessrrt@gmail.com. Happy to connect you with some resources there. Our section meetings are also open to the general RT population. So let me know if you're interested in that. I'll be posting them on AARC Connect as well, but invite you to join us for that and learn a little bit more about what we do and what we have planned for the section. Again, we've got a lot of things in the pipeline that we're really excited about trying to grow the section. We are still aiming to reach 1,000 members by the end of the year. It's an aggressive goal. It's a high goal, but you got to aim high to get anywhere, in my opinion. So if you happen to be catching this after the fact, please let me know. We've got a couple people out there who are doing some great work with recruiting some new RTs, student RTs, all that. I'm going to be doing my best to emulate that as we get into conference season here. I've got we've got be at the Michigan conference in early April, be at the Wisconsin conference in early May. I imagine there will probably be some other pit stops around, but I'm going to be trying to reach out to as many RTs and students as I can to get people into these roles, and just again trying to see what we can do to grow the section and grow all of our opportunities. So, with all of that said, I appreciate you, those of you who came out to check out the live today. And those of you who may be catching this stuck on my profile, because it looks like that's the only place it's going to be this week, with the quirks in YouTube and in Facebook. So please let me know, again, things you want me to cover, or suggestions you have for this section, other outreach opportunities. I posted a couple weeks ago about, about membership numbers. Our section was down a few members between last September and December when we got the latest updates, which is obviously not the direction we want to go. But I also really got some good insights about membership in general, and what people want to see from their membership organization. So I'm happy to be a point of contact for anybody who wants to discuss any concerns with return on investment or engagement or anything like that. I'm always happy to see what I can do to help things, because I know there are definitely a lot of things, a lot of ways we can engage better and things like that. But I will also say that there are a lot of misconceptions out there. Again, flying around all the social media out there. Not gonna name any one channel in particular, because everywhere I turn, there's just a lot of misunderstanding of roles and misconceptions and all that sort of thing. So I'm happy to do whatever I can to reduce some of that, reduce again, the confusion. And obviously I'm guilty of that myself. If people had a little bit of unclarity as to what these were for, but again, just we can always try to do better. So with that, hope everybody out there stays safe. Has a great weekend. Take care of yourselves, take care of each other, and we'll see you next Friday here on the AARC Ambulatory and Post-Acute Care Section office hours. Take care, everybody.